Good morning, guys. Welcome to the vlog. To all the new people, feel free to subscribe. Daily videos on my journey through med school happening now. I'm on my way to the clinic. There's not much to prepare for this rotation. I did some firecracker note cards on dementia and delirium, just because a large majority of the geriatric population at this clinic is demented, so I just want to have a good handle on that topic. I'm gonna leave my referral code for firecracker in the description below. You can use it for your foundations classes during first and second year of medicine. You can use it for step 1 practice and step 2. I plan on using it all throughout my course. I have a 1-year subscription. I think it ends September something or another, and by then I should have taken step 2 CK. Guys, I completely forgot. Wait, where are my glasses? I completely forgot that today was a lecture day. It is not even 11 o'clock yet and I am heading home. We just went over the 3 Ds of Geriatrics, which is dementia, delirium, and depression. Dementia, you know, comes in a bunch of different flavors. You could have Alzheimer's, you could have vascular dementia, Lewy body dementia, Pick's dementia. They all have their individual symptoms that separate them, but at the end of the day, it's all dementia. One big thing that she did stress, though, is knowing the difference between dementia and just normal aging. You know, when people are older, they're like, oh, you'll forget things when you're older too, la 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 la. But there is a difference between actually having a pathology and just aging. If you're forgetting things because you're regularly aging, the way you can separate that from dementia, there's no cognitive deficit that's affecting your daily functions. Like, say a demented person can't call their daughter because they forget, or they forget how to use a telephone or something like that. But then a person who's regularly aging can't call their daughter because maybe the arthritis in their fingers is preventing them from dialing the buttons. You know what I mean? So both people are unable to call their daughter, but because of 2 completely different reasons. Another way to separate normal aging from dementia is that you can teach an older person things and they'll retain it. You know, you can't really teach a demented person. You'll say something, they'll repeat it, and then they'll forget it. I feel like whenever someone talks about Alzheimer's, they always talk about football players and getting concussions and head injuries and all that stuff. So we touched on it a bit, but more the genes aspect of it. Like, if you have ApoE4, you are 10 times more likely to develop Alzheimer's disease after a brain injury. Isn't that crazy? 10 times. What in the world? But then if you have ApoE2, you're 1.5 times as likely. We reviewed some screening techniques. One for dementia that we use is called the mini cog, or mini cognitive test. I don't remember, I just call it mini cog all the time. That's the one where you ask someone 3 words, you ask them to repeat it, then you ask them to draw a clock. And when they're done drawing the clock, you ask them for those initial 3 words. If they can't repeat it, then you need to do some additional tests for dementia. If they can repeat the 3 words, then you're all good, no dementia. If they can repeat 1 or 2 words, then you gotta look at the clock. A quick screening test for delirium is a bit different. You need to check for altered change in mental status. She showed a pie graph where nurses are able to diagnose demented and delirious patients far more likely than doctors, because we don't actually spend the time. One of the screening tests for delirium is checking for inattention. And the only way you can check for inattention is if you're actually there talking to the person and seeing if they pay attention. But since doctors don't spend that much time with patients, you're never really gonna notice. Then you check for disorganized thinking. Finally, altered level of consciousness. The last D is depression, which I think is so difficult to diagnose in the elderly population. There is the PHQ-2 screening questionnaire. You can do is literally 2 questions. It's like, have you lost any interest in anything, and have you felt down lately? And then from then you go into more detail. But that's that, guys. The rest of the lecture was about medications that we give for Alzheimer's. So, you know, you give the central acetylcholinease inhibitors like donepezil. We went into some drugs for depression, but that's so difficult. You can't just say, oh, you have a geriatric patient who's depressed, you give them this. That's not it at all. It has to be individualized to that patient and the symptoms they're going through. If you need a sedative, if you don't need a sedative, if you don't need that much of a sedative, then you lower the dosage, and it's like, there's so much that goes into it. I thought it was a really good lecture, short, to the point. This doctor that we're working with, she's lovely. Like, her personality is fantastic. She tells us stories about the days when she was in residency and how her attendings talk to her and how to treat patients and encounters with nurses. She's awesome. But there's absolutely no hope of getting a letter of recommendation from her because she said so. She's not writing any more letters of recommendation, which is fine. I mean, I'd like one, but You gotta accept what the doctor says, you know what I mean? But that's it, guys. That's all I did today. If you want to continue following my journey through med school, please subscribe. Videos come out at 8 a.m. mostly every day. I don't want to say every day yet because I have been slacking, but mostly every day. If you subscribe, you'll see when the videos come out. I'll see you guys next time.